Thank you. Good morning, everyone. It's a great pleasure to present this topic with important clinical implication in primary care. I will start with the identification and importance of obstructive sleep apnea clinical phenotypes, then move to patients-reported outcome measures connected to these phenotypes, and finally, I will discuss the unique phenotypic presentation of obstructive sleep apnea in females. Obstructive sleep apnea is widely acknowledged as one of the most common respiratory diseases seen in clinical settings. Diagnosis involves measurement of breathing during sleep, and as you can see, diagnostic criteria require either 15 or more obstructive respiratory events per hour of sleep, or at least 5 obstructive respiratory events per hour of sleep combined with symptoms and associated medical and psychiatric disorders. These definitions indicate that there are also patients who present with OSA, but they don't have symptoms. This is something really important for primary care. And the clinical presentation, all these symptoms are a result of the underlying physiological mechanism known as endotypes. So it's important to know, especially for primary care settings, that OSA is highly prevalent, and general population-based studies have consistently shown a high prevalence of undiagnosed OSA, especially primary care settings. The prevalence in different studies conducted globally has been reported to range from 90 to 37% among men and 4 to 50% among women. As you can see, OSA is more prevalent in men than in women, but this difference that we will discuss later in prevalence appears to fade after menopause in women. Of course, there are other factors that additionally influence the prevalence of OSA, that are age and obesity. It's crucial to consider that the clinical spectrum of OSA now far surpasses the classical picture of that we all imagine the male, obese, and sleep patient. Now, there is a change in the population that affects diagnostic strategies because some patients are really more difficult to diagnose. A strategy to deal with this diversity involves categorizing characteristics into clusters, allowing for the recognition of clinical phenotypes with specific characteristics. These characteristics include, as you can see in this figure, pathophysiological, anthropometric parameters, symptoms like insomnia and sleepiness, long-term outcomes, biomarkers, and comorbidities. So why the clinical phenotypes are important? Because clinical phenotype identification facilitates the selection of high-risk patients for precision medicine approaches. So it's important to stratify patients with OSA for cardiovascular disease, to classify disease severity, to develop individualized treatment plans, identify responders versus no responders to therapy, improve primary cardiometabolic and neurocognitive prevention, and of course improve patients' reported outcomes measures. How we can do that? Of course, we can utilize all these characteristics that we previously mentioned. Of course, we have to take into account that it's difficult sometimes to have a reliable landscape that contains all OSA phenotypes across different patients' population due to geographical factors, lifestyle behaviors, and genetic background, patient's ecosystem, and socioeconomic status. Of course, there are many questions that we need to consider because we need to know why some of the patients develop diurnal symptoms regardless of the OSA severity and others do not. Are patients within the same severity have different susceptibility, for example, to cardiovascular or metabolic disease? How different pathophysiological traits results in symptoms expression, and what is the role of age, sex, and comorbidities? At present, there is no consensus of clinical classification of OSA. However, based on clinical significance, this is a figure that you can see that there are major clinical phenotypes based on age, on symptoms, on ethnicity, and also in sex. It's important, especially in primary care settings, to have a holistic approach, to have a good sleep questionnaire and have a good sleep history because there are many symptoms related to OSA. There are night symptoms, there are daytime symptoms. The most prevalent one and the most well-known is sleepiness, meaning inability to stay awake and alert during the major waking episodes of the day. But we have to consider that sleepiness is prevalent in the general population, 7 to 13%, 2 to 25% in the primary care populations, And 32% of all sleepiness could be secondary to other causes like medical or psychiatric disorders. Of course, we have patients that do not report sleepiness, it's 25 to 50%, and all of these symptoms that you can see, none of them are pathognomonic. Many patients have different kind of symptoms. How we will quantify these symptoms? We have patients-reported outcome measures that are directly reported by the patients without interpretation of the patient's report by a clinician or anyone else, and all these relate to patients' health, quality of life, and functional status associated with health care assessment. The American Academy of Sleep Medicine identified some of them. They're well known for sleepiness, quality of life, sleep quality, and mood. But we have to consider that in order to characterize the various clinical phenotypes, we cannot use isolated PROMs. Of course, we need to use a lot of PROMs to have a holistic approach, like the Epworth Sleepiness Scale for sleepiness, the well-known, the Fatigue Severity Scale for fatigue, the Patient's Health Questionnaire 9 for screening of depression, and also the Athens Insomnia Scale for screening for insomnia symptoms. So it's really important, and especially in primary care settings, to keep in mind in this, because it's really easy, especially for other healthcare professionals, nurses, or social workers, to work with patients with these PROMs, and now we have a clear picture about the symptoms of the patients. The first major attempt to classify symptoms in OSA was from an Icelandic group in 2014. They found 3 different clinical subtypes. The one is with the disturbed sleep group with mainly insomnia symptoms. The cluster 2 with the minimally symptomatic group, which is the more tricky one and more difficult to diagnose. And cluster 3, the well-known with excessive daytime sleepiness. Later, they tried to validate this in other cohort apart from the Icelandic cohort, and they find the same pattern of the symptoms with more clinical phenotypes. We also have data for the European Sleep Apnea Database in 23,000 patients. They also try to combine symptoms, OSA severity, comorbidities, and BMI, and find 8 clusters. But the important is the Sleep Health Study that did not also define many of these symptoms, but they also tried to correlate with prevalent and incident cardiovascular disease. And what they found is that the sleepy phenotype had increased risk for prevalent heart failure and also incident cardiovascular disease. That is really important and has many clinical implications. Now, we'll move more to the gender disparities, to the gender differences, because there is a unique phenotypic expression in females. So this is our data for the Hypnolo sleep cohort of 2,000 patients. They find the high prevalence of OSA, and the important thing is that they found major difference in men compared to women, especially before menopause. This difference seems to be more declined after menopause. They also tried to associate the OSA severity based on apnea-hypopnea index with comorbidities, and they found that hypertension was more common in women, especially after menopause. Diabetes was more common in men, metabolic syndromes in both genders, and depression mainly in women. Females, as you know, present differently than males. So in this study, we found that they had comparable symptoms of snoring, apneas, and sleepiness. However, females presented with more insomnia symptoms, more depressive symptoms, more fatigue, more morning headaches, more nightmares, more frequent awakenings, more restless leg syndrome, and more nocturia. Males, on the other hand, seem to have extreme daytime sleepiness and more driving problems. This is another study because mainly we don't have data from cohorts that have exclusively women, but this is the Spanish cohort that included about 2,000 women with OSA from a tertiary hospital sleep unit, and they tried to cluster all these symptoms along with comorbidities, and they found that the most common one was the one with the sleepiness, presenting 47% of the cohort, the middle age, with cardiovascular risk factor, follow it, but the middle age without symptoms and no cardiovascular factors, and the other two, the older without symptoms and the middle age with mood disorders, non-restorative sleep, and cardiovascular risk factors. Another cohort including only females, again from the STADA study, included 9,700 women. They also found 4 distinct female phenotypes, identified with different clinical presentation and comorbidities. And these data are really important because they may provide improved risk stratification, and personalized treatment. So we have differences well known, and OSA in women appears to be a distinct phenotype and may hold significant implications for our clinical practices, especially in primary care, identifying prognostic factors and guiding therapeutic decision. Therefore, we have to revisit all the guidelines, all the screenings, and to see how we can have more data in early diagnosis, potentially resulting in development of female-specific screening questionnaires. Of course, an important age limit for women is the menopause, so the prevalence, underlying pathophysiology, and symptoms differ not only between females and males, but also change after menopause. This is an important study because there are not prospective studies that could involve many women. And this study in hospitalized patients with acute coronary symptoms, they found that OSA was associated with increased risk of cardiovascular disease among women. And this is particularly evident here. You can see patients with OSA and with not OSA in the blue line. Okay, but you can see that the difference is more pronounced in women compared to men. Of course, the cost-effectiveness analysis have really important implications because a recent study found that women experience nearly double the economic cost before diagnostics. And this is the case because most of them remain unrecognized for a long time before come to the sleep labs. Therefore, this underscores the urgency of addressing this diagnostic gap. We need more data because we need data to characterize females and how they respond to treatment. We don't have many data. There are conflicting results, so more data we're waiting. So, many unanswered questions. We need more data because we need to have new screening tools for women. The traditional one, the Stop Bank Berlin and non-SAS have questionable performance. Of course, we also need to question, are traditional diagnostic methods valid for women? Because most methods and instruments assessing sleep have not been substantially tested for sex. And this also questions the accuracy of OSA severity classification based on apnea-hypopnea index. Of course, we want to know the impact in cardiovascular and other outcomes. Are they different in men and women? Are they different in age limits? And more questions about CPAP treatment response and what is needed in order to prioritize women for treatment. In conclusion, OSA is a heterogeneous disorder in terms of its pathogenesis and clinical expression. Females present differently from men and are harder to diagnose. There are different clinical phenotypes with probably different risk for cardiovascular metabolic disease, and the identification of these clinical significant phenotypes may be improved by combining all these characteristics symptomatology based on patient's history and the impact on the cardiovascular system and metabolism. Thank you.